Hi and welcome back to another video of Medic Notes. This video will be on internal fixation of fracture. In internal fixation, bone fragments may be fixed with screws, a metal plate held by screws, a long intramedullary rod, or nail, with or without, locking screws, circumferential bands, or a combination of these methods. These are some of the indications for internal fixation. First, fractures that cannot be reduced, except by operation. Fractures that are inherently unstable and prone to redisplace after reduction, such as midshaft fractures of the forearm and some displaced ankle fractures. Also included are those fractures liable to be pulled apart by muscle action, such as transverse fracture of the patella or olecranon, fractures that unite poorly and slowly, such as femoral neck fractures, pathological fractures, in which bone disease may prevent healing, multiple fractures, where early fixation reduces the risk of general complications, and late multisystem organ failure. Fractures in patients who present nursing difficulties, like paraplegics, those with multiple injuries, and the very elderly patients. There are a few different types of internal fixation, which include interfragmentary screws, wires, like transfixing, cerclage, and tension band, plates and screws, and intramedullary nails. The method used will be based on the situation and site of fracture. Here are some pictures. Picture A shows screw, B shows plate and screws, which is suitable for forearm or around the metaphysis. C is flexible intramedullary nails, used for long bones in children. D is interlocking nails and screws, ideal for femur and tibia. E is dynamic compression screw and plate, for proximal and distal ends of femur. F shows K-wires, and G shows tension band wiring, for patellar fractures. These are some possible complications of internal fixation. First, infection. Iatrogenic infection is now the most common cause of chronic osteomyelitis. The metal does not predispose to infection, but the operation and quality of the patient's tissues do. Second, non-union. If the bones have been fixed rigidly, with a gap between the ends, the fracture may fail to unite. Third, implant failure. Metal is subject to fatigue and can fail unless some union of the fracture has occurred. Stress must therefore be avoided, and a patient with a broken tibia, internally fixed, should walk with crutches and stay away from partial weight bearing for 6 weeks or longer, until callus or other radiological sign of fracture healing is seen on X-ray. Pain at the fracture site is a danger signal and must be investigated. Lastly, refracture. It is important not to remove metal implants too soon, or the bone may refracture. A year is the minimum, and 18 or 24 months is safer. That's all for this video. Thank you.